Okay, great. So welcome, and I want to thank you. And I want to also thank Cyndi Cramer, the clinical administrator at Tampa General and the palliative care educator, for sharing this important program with me. We last year did this program live in our Fitness Fun studio in South Tampa. We had about 25 participants. We did a lunch and learn. So it was a well attended, and everybody got a lot from it. So this year, I thought, because of the current COVID-19 situation, that we would try Zooming the material. So I'm going to go ahead and begin. I want you to ask you if you would save your questions for the end. Go ahead and write your questions down, and then we'll take some time at the very end of the program to discuss any questions or comments. I'm going to mute you as needed, so you may have to unmute or mute yourself. You can do that too. If please, if you're experiencing any background sounds, anything that might be disturbing, go ahead and engage the mute feature now. And that way also your private conversations won't be recorded. Okay, and I want to really acknowledge, take this opportunity. I'm going to share my slides now. See if I can do that. And these, in essence, are Cyndi's slides. So she was kind enough to share this program. It's a very important program for all of us today, especially now. But I want to take an opportunity to acknowledge and thank all the healthcare providers that have come before us to pave the path. And I want to make a mention of the Tampa General Hospital palliative care resource nurses and the palliative care resource professionals. This is a very dedicated team of professionals, and I've been on the team for over 10 years. For those of you that don't know me, my name is Gabrielle, and I've worked in healthcare over 25 years. I'm a registered nurse. I have a master's degree in nursing from USF, and I work in the radiology department at Tampa General. I love my job. And I also started working with meditation to help me personally relax and reduce stress. I eventually went on to achieve my national board certification as a meditation specialist. So I teach private and group classes virtually. We explore and experience all types of meditation. Last week, we took a virtual mini meditation retreat where we practiced mindful eating, and we also did some restorative group meditation. Every class is unique and relaxing. So that's a little bit about me and what I do. And I want to thank you all for taking the time to attend and address this topic. The Elephant in the Room by Terri Kettering. There is an elephant in the room. It is large and squatting, so it is hard to get around it. Yet we squeeze by with, "How are you?" and "I'm fine," and 1,000 other forms of trivial chatter. We talk about the weather, we talk about work, we talk about everything else except the elephant in the room. There's an elephant in the room. We all know it's there. We're thinking about the elephant as we talk together. It's constantly on our minds. For you see, it's a very big elephant. It has hurt us all. but we do not talk about the elephant in the room. Oh, please say her name. Oh, please say Barbara again. Oh, please, let's talk about the elephant in the room. For if we talk about her death, perhaps we can talk about her life. Can I say Barbara to you and not have you look away? For if I cannot, then you're leaving me alone in a room with an elephant. So let's talk about death. People used to die at home, but not so much anymore. And a little background, approximately 2.5 million deaths occur in the United States every year. Back in 1949, 50% of those deaths occurred in the hospital. Now flash forward to 2001, and that figure is up to 60 to 80% of all deaths occur in the hospital. So let's look at that. 10 to 69% of ICU patients will die. 20% may leave the ICU, but die in the hospital nevertheless. In California, 81% of patients preferred to die at home, but 56% die in hospital. So in California, there's a 42% mortality rate for patients admitted to the ICU. So as you can see, we do need advance directives. First advance directive started back in 1967, but it wasn't a big deal until about 1976 with Karen Ann Quinlan. When she was in the headlines, you might remember that case back in the 70s. And let's talk a little bit about the cost of dying. So a hospital death costs about $1,000 per day. A nursing home runs about $1,000 per week, and hospice is $100 per day, including medications. So there's a big gap in the cost of care. And let's look at our life expectancy. Back in 1900s, life expectancy was about 47 years old. And in 2003, 77. And that number continues to increase, although I think it's leveled out a bit right now. Now let's assess and compare the direction that we've gone and how we've progressed from then to now. So back then, dying was all about comfort, easing of suffering. And now we're focused more on curing at all costs. In the past, infections were the main cause of death. And now it's chronic illness that is the main cause of death. Life expectancy back then was about 50. Life expectancy now is about 80 years old. The caregivers of the past were family, and people died at home. Now, caregivers are strangers, and more of us are dying in an institution. In the past, there was a short time frame until death. Now, it's prolonged time with ups and downs. And end of life in the hospital. Unfortunately, our physicians aren't really adequately educated in school about death and dying. Some doctors may view death as a failure. rather than a natural process. Death used to be familiar in the past, from old age, but our culture has changed. And now death is a disease to be conquered in many people's perspective. People can be kept alive with chronic illnesses, and they are rescued from multiple exacerbations. Chronic illness is now unpredictable. It used to be that you could see the writing on the wall and expect death when it came. It was rather predictable. But death is no longer looked at as a natural outcome, but a failure in the eyes of modern medicine, who may measure success by one more day of life. Okay, I love research. Let's look at a study from 1995. And of course, this is remote history, but over 4,000 patients were included in this study. And the findings revealed that 45 or 47% of physicians were unaware. They had no idea that their patients preferred to be a DNR. And it's possible that they were never even asked about their preference. Almost a third of patients who wanted a DNR order never talked to their doctor, and many of them died before discharge. 46% of DNR orders were written 2 days prior to death, and 38% of patients spent 10 or more days in the ICU before dying. 50% endured pain at death. So this is not a pretty picture. And there is a disparity between the way people want to die and the way people die. The process involves many fears, and the patient perspective includes things like pain, burden, prolonged death, dependence on others, other symptoms, abandonment, role changes, and financial concerns. So how can we bridge this gap? That's what we're going to talk about. Now, this is a drawing from a nurse that attended one of our first end-of-life courses at Tampa General. And this is a drawing that she submitted of how she wished her dad had died. And in this depiction, this drawing, he looks relaxed and tranquil. And the next is how her dad actually died, in the ICU with all the tubes. Probably not the way that he might have planned it. Now, I want to share this quote from Mother Teresa. In third world countries, people die with their hand held and their pain managed. In the modern world, people die alone, in pain, and with technology in abundance. So is this where we want to be? This is especially true today with the COVID-19 pandemic. People are dying alone in the hospital every day. And this is the technology age. There's a sense that we're morally obligated to do everything that we have. And this is a slippery slope. We're saving babies, as an example, earlier and better, but many suffer with mortality and morbidities in the process. It's easy to just add one more thing until we don't know if we're extending life or prolonging death. So the question is, have we become prisoners to our technology? If the ICU patient has a 95% chance of death, do we feel a moral obligation to try for that 5% chance of survival? That's where the slope gets slippery. So let's explore palliative care. What is palliative care? Who benefits from this? Who is this for? So this is for anyone with a life-limiting illness. It's not just for those who are actively dying. And really what it's focused on is quality of life and symptom control. So you have to discover here your own personal goals. And this involves difficult conversations. And it's always good to get expert advice. But whatever information you receive from other people, you can elect to receive aggressive interventions if you wish. It all depends on what you want. It's all about you. What are your goals for the way you want to deal with a serious illness and ultimately your life? So looking at quality of life, this is a multidimensional experience. It's about all aspects of you. So your physical, looking at functional ability, strength, your ability to rest and sleep, issues with nausea, appetite, constipation or pain, all those physical elements. Then we have the psychological aspects. This includes anxiety, depression, your sense of pleasure, any sort of feelings and associations, emotions with pain. It also includes happiness, and it might incorporate your fears, your ability to think and pay attention. All those are all important elements of our psychological well-being. In addition to those other aspects, we have social aspects of quality of life. And this includes financial, caregiver, different roles and relationships we have with people. It interferes with our affection and our sexual function. And it also impacts our appearance, which can impact us on a social level. Then there's spiritual, hope, our relationship with suffering, the meaning of pain, and any religion that we are connected to, and transcendence as well. So there's a lot to think about, what we really need and want in our lives. And we need to really look at the benefits versus the burdens. So if you're in a situation where the benefit of a longer life might have stronger weight than any burden of pain or suffering, your own comfort may be more important than suffering. And then again, looking at your relationships, your caregivers, the technology that's available. Other community benefits are the people in your community and resources versus isolation, our ability to communicate and reach out versus immobility. So weighing all the benefits and the burdens to determine what you want, what you really need. Now, these are the top illnesses. There are others, and don't forget about trauma that can be an end-of-life event. At the top of the list, we have COPD. Now, COPD has a worse prognosis than stage 1 lung cancer. It's got about a 50% 5-year mortality. So if you've been diagnosed with COPD, you have about a 50-50 chance for 5 years. And approximately 60% of people with COPD get admitted to the ICU and end up on a ventilator within a year. Now, 23% of people that have COPD are unaware of their diagnosis, and they don't really understand what it means. They don't understand it as an end-of-life disease process. It doesn't really have a cure. But 83% of COPD patients have not discussed end-of-life plans with their physicians. but they wanted to. 78% wanted to talk about it. And in this particular study that I'm referring to, 12 patients had been on a ventilator over the last year. And 50% of those said they didn't want to go on the vent ever again. So when you're in this, these are the terminal illnesses that we don't have a cure for yet. It's just true that some things cannot be fixed. And the reality is that we can't fix everything. We can't change the inevitability of our death. We cannot erase the anguish we feel when someone we love dies. And we must face the fact that we too will die. No matter how hard we try, the perfect words or gestures rarely exist. And very often, it's enough to just be with the person that's dying. When we accept that death is inevitable, we can offer our presence as a witness to the process. And it's all about you. So even though we don't get a choice whether we die, we can make decisions around this issue. And that's empowering. So the next slide is the team. I love this one. The patient is the leader. Notice that. It's all about patient-centered care. And everyone else below the patient is equal. The slide just doesn't allow us to show that. You know, everyone plays a different role. We have an interdisciplinary medical team, and then we have a support system on the opposite side, and then we have the multidisciplinary team of medicine, doctors, nurses. So it's quite a gathering, bringing all those aspects together. And that's part of the goal of the advance directive. What is an advanced directive? Now, this is according to the Tampa General Hospital policy. This is their definition. A witnessed document or an oral statement in which a competent patient makes healthcare choices that take effect in the event the patient loses decisional capacity. Other names for this are a living will, power of attorney for healthcare. So those are other ways to say advance directive. And keep in mind, if there's several versions of an advance directive, we go by the most current date. So this is a dated document. Now we have to have capacity when we make our advance directive. So what is that? How do you assess capacity? Well, capacity is determined by a physician. When a patient is sick or unable to make decisions, this could be temporary, related to an illness or medication. So your assessment of capacity is basically determined by a doctor, and it may come and go. May again be related to your illness state or medications that you're taking. But competence is different. Competence is a legal term, and competence is determined by a judge and can only be revoked by a judge. And when that happens, if you don't have an advance directive, typically they assign someone. The court will assign someone to make your personal decisions. Now, patients have rights to accept or refuse care. So we, as patients, have a right to determine what we want done and what we don't want done. We have a right to have an advance directive. And when we have that advance directive in writing, providers are obligated to follow your wishes. So these protect your choices when you're decisionally incapacitated. Now, the 5 wishes, I included this in your documents I sent you via email when you registered. Unfortunately, it's not a printable version. So I'm going to continue to research how to get a copy that we can print and complete. I really liked this. So in addition to healthcare decisions, these 5 wishes include the person I want to make my care decisions for me when I can't. So that would be your healthcare surrogate. It also talks about the kind of treatment that you want or you don't want. It covers how comfortable you want to be and how you want to be treated and what you want your loved ones to know. So this was expanded. I really liked it. Now there's a Project GRACE, which is now Empath Health, which GRACE stands for Guidelines for Resuscitation and Care at End of Life. So this is offered through hospice, and it gives you treatment choices, talks about different ways to make some of these decisions, helps you understand the choices regarding CPR, things like life support, surgery, whether you want to receive blood or blood products, if you want to consent to receive antibiotics or have lab work done, or if you want a feeding tube placed or not. And, you know, treatment choices are influenced by your chance of recovery. Also, whether you have an end-stage disease, whether you're permanently unconscious or permanently confused. Or you may be even totally dependent at some time. So your healthcare surrogate is going to make all those decisions for you if you haven't talked to them about what it is that you want. So think about that. CPR and having life support when you're at end stage. And forms and laws do differ by state. So I'm typically talking about Florida, the state of Florida, but some of you are from other regions. So some states prefer a power of attorney for health care. That is the terminology that they use. And some will want your signature notarized. So some states do require your advance directive to be notarized. Florida does not require a notary, but they do require 2 witnesses, and they cannot be the same person as your healthcare surrogate. So if you're picking, let's say, your sister as your healthcare surrogate, they can't serve as a witness in the state of Florida. You have to have someone else. And you can change your mind about this. It isn't written in blood. So as your goals change, you can update your advance directive. I know, there might have been a time in my life where I thought getting around in a wheelchair would be completely unacceptable. But now I've ridden around on those carts, those motorized carts in the grocery store. And you know what? I could do that for a couple years, no problem. So you can update your advance directive and decide how to change your care as your goals change. Okay, and don't really worry too much about your doctor trying to hurry you along. It's more than likely the opposite in some cases. Now, let's just take a moment and talk about organ donation here. Make sure that you talk to your surrogate or you document what you would like regarding your choice on organ donation. Almost anyone can donate something, and you can specify certain organs. But even if you have a donor card in your wallet, your family can refuse this option, especially if they don't know what your desire is. Okay, you can give the gift of life to another. So think about that too. Now, let's say that you decide that you're not quite ready yet to make this decision, but keep in mind that not making a decision is making a decision. And this is a list. This slide lists the caretakers who would take charge if you didn't name a surrogate. Now, obviously, the first substitute decision maker here is the patient surrogate. So if you've chosen someone, they're at the top of the list. Secondly, if you haven't chosen a healthcare surrogate, but you have a legal guardian, this is typically for kids. They go second on the list. Now, if you don't have a legal guardian or a healthcare surrogate, then it goes to your spouse. Now, this is your legally married spouse. So this could be, we've seen situations where the spouse is no longer in the picture, but they're still legally married. And that person from your past would come in and be given all the power to make all of your healthcare decisions. After the spouse comes adult child or the majority of children. Then would be a parent. Now, of course, this would be first for children. This person goes way up to the top of the list. Then we have an adult sibling or the majority of siblings. Then we go to an adult relative, followed by a close personal friend. And for this, you would need an affidavit, something in writing, typically. And if none of those people are present, then it goes to the physician, and they require 2 physicians, and they basically would make all of your healthcare decisions. So you can see how important this is. And please remember, this is for the state of Florida. Every state is a little bit different. So whatever state you are making your advance directive, find out what the specifics are. But this, when I read this list, it made me nervous, and it really motivated me to get busy. All right, so now let's talk about what is a DNR or a DNRO. So a DNR is a form, and this is signed by your doctor. And this basically tells healthcare personnel, wherever you go, not to perform CPR or perform any extraordinary measures. Okay, there's other names for this. It varies a little bit state by state. There is a DNAR, which is do not attempt resuscitation. There is an AND, which is allow a natural death. I kind of like that terminology. And then CMO, comfort measures only. So those are some of the initials in the alphabet soup. The DNRO is the state of Florida DNR form. It's recognized and honored throughout the state. Okay, and this is a legal document. It must be honored by healthcare providers in the state of Florida, but you do have to have the original copy. And again, it's signed by a doctor. It's yellow in color, so it's really easy to distinguish the original copy. Again, it's signed by your doctor. So that's a DNR and a DNRO in the state of Florida. Now, you can tell your doctor or document in your advance directive that you want to do everything. If you want everything done, you can choose that. But what does this cover exactly? So this might include repeated or prolonged CPR. It might include spending some time on a ventilator. It might include multiple procedures and tests, dialysis, implanted defibrillators. Sometimes they decrease your pain medication to make sure that you're still awake. And keep in mind that 92% of patients report getting their medical information from TV. So some of these things aren't as glamorous, I can assure you, in the real world. On TV, 75% of people survive CPR, but in real life, it's between 6 and 15% that leave the hospital. So it's not quite the same picture. And let's just take some time to ask yourself, what does a peaceful death look like? You know, how do we envision this? And, you know, you may have participated in this with some of your family members. I know I have. I was there for my mom at her death, and we did alleviate suffering for her. One of her goals was to die at home, and we got to make that happen. Reviewing one's life and finding ways to enhance the quality of life, having a death that involves dignity, and really the gift of love. It was such a great gift and such a meaningful time for me to be there and comfort my mom and really sort of help walk her home. But keep in mind that there's no right way to die. You have to be realistic. Crises and difficulties are going to arise along the way with unexpected bumps in the road, but moments really of profound joy. Flexibility is essential, but stay focused on your goals of care. You know, when you do your advance directive and then you hit a bump, you can remember your goals and stay on course. Remember, this is about you and your goals, what you want. And some of the lingo that you may hear related to this topic. Know what that means, withdrawing care. You know, remember, this is not about withholding care. It's not about not doing anything else or stopping all treatments. It's about comfort measures, focusing on comfort and care, all the things that we can do for comfort and quality of life. Your goals are going to determine the treatments. So keep that in mind. When I wrote my advance directive, I chose to document that I would want tube feedings, but just for a short period of time, very limited window, like a 30-day window. And then, you know, the withdrawal of that, giving permission for the feeding tube to be removed, and then getting ice chips instead to keep your mouth moist and just be comforting, those cool ice chips. So remember, it's about focusing on care and comfort. So who do you choose for your healthcare surrogate? Contemplate what your options are and work with who you trust to uphold your decisions. So a lot of the participants from last year discussed how the person that loves you may not be able to let you go in the moment. And even though you have parameters, they may forget all that and let their feelings, their emotions override your wishes. So please choose wisely. And again, remember, not making a choice is making a choice. Now, families get torn apart over these disagreements over end-of-life issues. And let's talk for a minute about the sad case of Terri Schiavo. For those of you that don't remember, Terri Schiavo was in her early 20s, and she was she suffered an anoxic event. My understanding is it was a heart attack related to an electrolyte imbalance. So she had an eating disorder, and her eating disorder caused an electrolyte imbalance, and she had a massive heart attack, was the story. And do you guys remember that video they showed over and over where they had Terri's following the balloon bouncing in the video, and it looked like her eyes were tracking the balloon? They showed that one over and over. So on the right, we have a little picture of the normal brain, a CT of a normal brain, and then Terri's brain on autopsy. The brain tissue was basically gone. Her brain was just full of fluid, and she was also blind. Originally, when she had this event, her parents and her husband worked together to implement extraordinary measures to cure her. They traveled to California for experimental treatments. They did things for years until her husband went to nursing school and decided they had done enough. He remained married to her, so he would be the legal decision maker. And in the end, ultimately, he did win legally the right to allowing Terri to die. But they ended up hating each other, and they went through years of legal battles. The husband claimed that she had once told him that she would never want to live like that, referring to her state, her vegetative state. And that may or may not be true, but he had all the power because he was the legal. So where should you keep your advance directive? Once you complete it, you should make copies, multiple copies, give one, of course, to your surrogate, and then your physician, family members. Keep a copy in your wallet if you can, or your purse, maybe your glove compartment of your car. You can give one to your spiritual leader if you're a member of a church, and give copies to any facility that you go to for medical care. One participant claimed that they kept it in the freezer, so that way it would withstand any sort of a like a traumatic hurricane event. I thought that was an interesting idea. And these photos reveal how we can lose our patient and ourselves beneath all of the technology, or feel a residual regret for how things may have progressed. But this is what most of us want, to just be surrounded by our loved ones. And even this is impaired by our current COVID-19. And these family members may be just outside the room, looking through the glass, looking on. So there's so much to consider. So is it time for you to complete an advance directive or update? I just updated all my end of life documents and wishes recently, and what a relief. I found a great sense of peace now that it's done, but it is hard. How do you pick, did you pick your surrogate? And where do you keep your documents? Have you told your surrogate, had the conversation, as well as your family members? One of my dear friends asked me if she wanted to update her advance directive and her husband did not. So just to address that, you can update your personal advance directive if your wishes are different than your spouse. You can choose her surrogate different from your spouse, and you can, if your spouse wants to not make a choice and not make a decision, that's perfectly okay. Again, they would just leave you or down the line, you know, to make all the decisions for them. So, you know, having this conversation is important. Here's another great quote by D. Annemund. Science says we must live and seeks the meaning of prolonging, increasing, facilitating, and amplifying life, of making it tolerable and acceptable. Where wisdom says we must die and seeks how to make us die well. So please talk about it. If you don't, you or your loved one may be left alone in a room with an elephant. So we have some time for questions or comments. You may have to unmute yourself, but we have some time.
I put a question in the chat, but I'll go ahead and ask it now. Can you hear me?
I can hear you.
Okay. When you say that your doctor needs to have signed the DNRO, which doctor? Because, we have multiple doctors at this age, and it might not be the one who's actually taking care of us. Even if I have a cardiologist, that cardiologist may not be the cardiologist who's actually taking care of me at that time. So I guess you solve the problem by carrying it with you wherever you go, but who signs it?
I think that's a great question, by the way. So that would depend upon your medical diagnoses. And typically your doctors don't, just if you ask them for it, they may not sign it. These typically pertain to patients that are experiencing terminal diagnoses, like cancer, if you have an end-stage heart disease, CHF, COPD. So it sort of depends on the doctor that's treating that life-limiting condition. So if you had a current COPD diagnosis, so your pulmonologist might be the doctor to address that with. If it's your oncologist, if your diagnosis is a life-limiting cancer diagnosis, then they would be the ones to address that with. And typically that's something that they like to negotiate. So again, you're going to have this conversation with the doctor. And sometimes they get a little uncomfortable with it. So don't be surprised. Let me know how that goes.
So I guess what you're saying is you need a directive in any case, but then when you actually get to that point, you do the DNRO?
Correct. In most cases, your doctor wouldn't sign you up, like your primary doctor wouldn't sign you up just for a routine visit.
Okay.
It's not something that they do for everyone. They want to have a conversation with you about your condition. And, you're going to have to ask them questions about your prognosis. What's the trajectory for the condition that you may be facing or that you are facing? Yeah, so which doctor for your DNRO would depend upon your medical diagnosis, but great question. And I think the more that you talk about with your doctor, if you wanted to mention maybe now, hey, I'm filling out my advance directives. I want to give you a copy. And it's typically for people, though, that are facing a terminal condition, Vivian.
Okay. Thank you.
Mm-hmm. Great question. So good to see all of you here. I'm so proud of you for addressing this topic. Any other questions or comments about the program?
It's sobering, but we need to hear it, so thank you.
Yes, it is sobering. And right now, especially with COVID-19, because that seems to be less age specific. We've had patients at Tampa General that have faced their death before their time under that circumstance. So it is sobering.
So you would suggest that even our adult children should maybe be doing the same thing we're doing?
Certainly. Yes, absolutely. Because imagine, again, not having the conversation, and then as a parent being put in a situation where you're making these end of life decisions for your adult child. And even just having the conversation, it seems I noted in one of the slides that it can be just an oral agreement with somebody. So just taking the time to have this conversation about what would that look like. I loved how the nurse shared the drawing of her dad and how she envisioned him at death. with his little toothpick in his teeth, just sitting back and relaxing.
And he had his glasses on.
Yeah, exactly. So a lot of it's the little things, but keep in mind that you can plan to have music. You can ask for specific people. You can really create and make this as much detail as you would like. But the key is communicating your wishes. That's the hard part. I mean, I remember having a conversation with one of my relatives that was getting close to dying, and they get scared to talk about it because they feel as though they're sort of inviting death. Let's not talk about this now. You're trying to kill grandmother off, that sort of feeling. They get very nervous. So a lot of deep breathing and, again, printing or emailing that document with the living will and the advance directive and some of the information to someone that could benefit from it. Send it out to your kids. It's really a great gift.
I know Peter has the harpist who comes to his classes, and she apparently has a therapy where she goes to where people are dying and plays music at the time. I think that's pretty beautiful, something I wouldn't have thought of. But if it needs to be written down, I don't even know if it's allowed in hospitals or if it's just in hospice care. I don't know.
I think it can be both. And I think, according to my nursing information, that's one of the last senses that we lose is our sense of hearing. So I could imagine that would be really powerful. All right, guys. Well, thank you. We're just about out of time. I will email out the 5 wishes if I find a printable form for you all. And if I don't, I hope to see you in the next Zoom room. So